All right, a very good afternoon, everyone. Thank you so much for joining today. All right, we are going to keep it really, really fun. In the sense, we're going to keep it interactive, so please don't feel obligated. Just keep it interactive. Shout out the answer if you know, okay? And I'm sure all of you are wondering as to why you have a piece of paper in front of you. And for those of you who do not, please grab your phones, and I'm sure all of you have my number, okay? So please text me. So we are going to take 30 seconds and basically think about one artifact you've encountered, if at all you've encountered, and also name of one artifact, okay? So I'm going to give you 30 seconds. Please write it down. Yeah, or text me. 30 more seconds. So the task is to text us one artifact, like name of one artifact you've ever encountered. And who don't have a paper, please text me. Because our intention is to cover all those weird names or weird artifacts you've seen, right? So we want to do that. And also, one important thing, before even we get into artifacts, I think one important, very important one is also know about anatomical pitfalls, right? So we encounter different variants of anatomical varieties of stuff. So we need to know what they are before we start interpreting what are artifacts, right? So we're going to keep it basic, keep it simple. So like I said, feel free to interrupt you if you want to talk about something in particular. Sadly, I don't have any disclosures. Now let's take a quick look at this video. Are all these balls moving in a circle? What about this one? Which direction is the idle moving? So what I'm trying to get to the point here is that we make a lot of assumptions about ultrasounds, right? And it's always not clear when it comes to ultrasound artifacts, and we need to know the application of ultrasound physics before we start interpreting these artifacts. Why are we talking about artifacts? Why did we even include this in the topic, right? So very important, because we always want to think about what are the normal variants like we just talked about. Always apply ultrasound physics when in doubt. Can change clinical management, right? Depending on what you say. If it's an artifact, we do nothing about it, versus if you call it something significant, it alters clinical management. It's important to consider that true anatomy is always visible, right? And artifacts are not always visible in all the views. And again, if it's not clear, don't hesitate to get further imaging, right? And thanks to our institute, we have multimodality accessible with the click of a button, so don't hesitate to use multimodality. And finally, always think about the third dimension, right? Like I know we have 3D readily accessible now, but everything you see has to make logistic and anatomical sense as well. All right, now this is the second task we are going to have today. So please take out your phones, all of you. So join this website on any of the browsers, menti.com. And I hope you can see the passcode. It's 16442721. All you need to do is put the passcode and say join. There you go. Keep voting. Oh, I love this person who said don't know. All right. I think we have a majority, right? I think most of you have chosen artifact, which I think is correct, but again, we're going to talk about this in the next few minutes as well, okay? I appreciate the people who said don't know. So our goal at the end of this lecture is going to, convert you into the right answer too. All right, how about this one? So what is the next step when you see this? And the options here are anticoagulate, do blood cultures, do nothing, or don't know. All right, I'm going to have everybody who's saying do nothing tell me what it is. That's good. All right. How about this one? Is this pacer in the left ventricle? Is this pacer in the right ventricle? Or is there no pacer at all? We are just seeing some kind of reflection. Again, don't know. Keep voting. Someone is thinking it's in the LV. All right, I think, well, the majority of you said pace it in the RV, which is correct. But I'm sure there's that hesitation in saying, is it really just in the RV? Are we seeing a portion of it in the LV? Is it perforating through the wall, right? That's the question we have. So we need to know, is this an artifact or is this real, right, guys? So very important to know these basic routine day-to-day, things which we see and understand the ultrasound physics behind it. All right, so what are we going to do today? Identify anatomical pitfalls, identify some ultrasound artifacts and apply some principles. Tips on interpreting, because not just knowing these artifacts, right, especially for the sonographers in our room, we need to talk about how to avoid these. And finally, differentiate some real structures versus artifactual structures. All right, we have an ambitious agenda, but we're going to keep it simple. And I know I don't want to use too much of the technical terms because we want to get through the point and not the term itself. Let's start with ultrasound assumptions and points to remember, right? What do we assume in an ultrasound system? So first of all, we think that sound always travels in a straight line. So we think it doesn't really go around. We also think that sound directly hits to the reflector and comes back only once. That's another assumption we make. We know that in reality that's not true. And again, sound travels in soft tissue at exactly 1540 meter per second. And for all the fellows who have not taken the echo boards yet, this is one important number to remember, 1540 again, right? And then we also think that reflections arise only from the structure's position in the beam's main axis, which is again not true, because there are so many structures in the same axis which can also reflect the ultrasound back. And we also think that the imaging plane is thin. In reality, we all know that's not true. And finally, we think that the strength of the reflection is related to the characteristics of the tissue, which is partially correct, right? And not completely correct. So let's quickly move on to pitfalls. All right, again, I want all the fellows and sonographers, please feel to choose your favorites. I'm sure all of you have your own favorites. So maybe let's start with our imaging fellow, right on the top. All right, I'll let you choose the first one, Alba. All right. All right, maybe before I give you the answer. So what do you think about the first one? It's hard to say, right, without giving you a proper clinical background, right? So the first one is a patient who's older. And if you also look, I mean, the annulus is also a little bit calcified. And if you think about it, it's actually a prominent Coumadin ridge, which is a totally benign variant like we all know. Again, it's most often seen on TE studies where you can really clearly see the prominent Coumadin ridge. But there are occasions where you can see it on the echo as well. What about the second one? If I did not give you the history, you wouldn't know, right? So if I told you this is a cardiac transplant study, then I think it's easier to know that it's just a prominent suture line. And it's also important, so what do you do, Gina, if you see something like this, right? You look at the prior echo and see if it existed on the prior echo. Because that again gives us a clue, has this been there forever since the surgery? All right, I think we're done with the LA. How about Rasha? What's your favorite? All right. Right side. All right, I'll take the RV and the right side. Right, what do you all think about the first one there? I'll point it out for you.
RV is enlarged.
Okay. And what's that structure we are seeing there?
Probably the moderate to left. We're talking about the right.
The first one, the first video on the left. It's in the AV groove, right, guys? What are the structures in the AV groove? Coronary sinus, yeah. That's a dilated coronary sinus. And we know what are the causes of dilated coronary sinus, right? Elevated RAP, definitely. But one thing which has to strike in the mind is persistent left-sided SVC, exactly. And for that, we do basically, you get an IV access on the left side and inject, agitated saline contrast on the left side. What about this one? Yeah, that's just a prominent moderator band. Especially when the RV is dilated, sometimes you can see it more prominently. What about that?
Calcified annulus.
That's good. That's just TAC, right? So it's tricuspid annular calcification. But again, the other clue in this one too, Rasha, if you see the mitral annulus is also pretty calcified. So that's another clue. All right, I think we are cruising along the anatomical variants pretty fast. All right, I think the favorites are taken, the right and the left atrium. Nobody likes the LV? Yeah? Oh, somebody wants the others. All right, we'll go for the others. Thinking outside the box. Let's see if any takers for this one. I'll point out what we are looking for. Oh, I gave you the answer. So this is also a very common question actually in the echo boards, right? So a lot of people think, are they showing a dissection flap? If you look on the top, it's kind of confusing. But actually, it's a normal brachiocephalic vein. You see it on every arch shot. So after you go back to the echo lab today, or even if you're not, just pull up an image and see most of the arch shots have the brachiocephalic vein in it. What about this one? So at least it's not in the heart, right? So it's a loculated ascites actually, and you can see it's pretty bad. What's this? What's that haziness which is covering the heart? Is it inside the heart? You guys know that better, right? All the sonographers can vouch for this. Yeah, it's a shadow from something. It's a breast implant shadow, right? And if you see how it's kind of covering the whole view, right? That's from the external influence, right? What about this one? This is Clara's favorite. What is that which is lighting up? What's that? Yeah, it's a hiatal hernia, right? And what are we making the patient do, Salim? Soda. All right, so that's a hiatal hernia. Again, remember, so this slide is to show the importance of thinking outside the box. I mean, we are clinicians, we are cardiologists, so it's not just about the heart, interpret outside the box as well. All right. Any takers for the LV at all? Or you want to jump into valves? How can we not do valves? Dr. Little is here today. All right. What are these? Did you ever see these? Yeah, actually, those are prominent insertion points of the chorda, right? When the patients are very young and when the tissue is very nice and thin, you can appreciate these chordal insertion points. And especially on TEs, you can see them even better. And again, these are just fibrous nodules on the margin, and these are totally benign again, right? Completely normal variants. Lambel's excrescence, right? How many of you have seen this so far? I think anybody who's done TEs so far have seen that once at least, right? So again, these are filiform nodules seen on the, or I should say fronds, seen on the aortic valves. Again, the pathology is very frond-like appearance. It's pretty much a degenerative tissue which we are seeing. Are these important? Yeah, maybe in the setting when they are bulky and more finger-like. They are actually fibroelastomas. And Lambel's are more commonly seen at the lines of closure versus fibroelastomas are seen on any sides, right? Are these always benign like we are thinking? What do you think? Actually, not quite, right? So there are some case reports where if you don't really see anything, they think that it might be the embolic etiology from the fibroelastoma itself. And again, there are lots, there's a lot of data coming out on these about, okay, what do we do if we have patients who have recurrent strokes and you see this on the TE, what do you do? So in fact, if you do, if there is no other etiology, they do recommend a trial of anticoagulation as well. All right. I think I feel left out for pericardial sinuses. We'll go with that. All right. Again, everybody have to know what are the anatomical normal variants of pericardial reflections. These are the pericardial sinuses. The transverse sinus, again, sometimes you can appreciate it better on TEs, usually between the aorta and the pulmonary artery. And the oblique sinus is the one which you see right behind the left atrial appendage, right? And sometimes, why are we talking about this? What do you think about this one? And if I tell you this patient has a lot of fat around, around the heart, prominent epicardial adipose tissue, and the patient has pericardial effusion. So this is nothing but just fat in the, pericardial sinus. You're just seeing it more prominently because, there is effusion and there is a lot of fat, right? So important anatomical variant to know, because this is another misleading one which we can, think maybe it's just thrombus in the appendage. And what we are actually seeing is not the appendage either. All right, somebody has to choose left ventricle. I feel bad. All right, I'm going to show you all four here, but I want you to guess which is the odd one. I think we can say A, B, C, D, and this is the D.
Which is the odd one?
Yeah.
Which one doesn't belong?
D, I guess, right? I heard D. Or the fourth image at the bottom, right? I mean, you can clearly, if you just ignore the other three, right? If you just look at the bottom right one, it's a clear apical aneurysm, right? So we don't, and I know you probably, will cover the other three, but, it's important to know what's abnormal too, right? So in this case, how do you differentiate aneurysm versus pseudoaneurysm versus diverticulum? Again, if I'm sure all of you have encountered this at least once. Aneurysms are typically apical versus diverticulums are usually, pretty small and they can be in variable locations. Again, the wall motion is preserved in a diverticulum versus an aneurysm or a pseudoaneurysm. You clearly know it's a clear outpouching. And if you do an MRI, obviously you're going to have enhancement of the, if it's a scarred myocardium, you're going to see that, versus if it's a diverticulum, you don't see that. Here's a nice, cute picture of the MRI showing the apical LV diverticulum, and you can clearly see it's moving with the heart. Right, guys? All right. So I think we covered all the anatomical variants so far, right? Did we miss anything? Did we cover everything? What is the next step when you see this one? So do nothing, order a TEE, start anticoagulation, or perform additional imaging, biplane, multiplane, color Doppler, and 3D if we can, or just go ahead and order a CT. Please don't say that. D, okay. Any other? What do you?
Echo, you might just easily say,
All right. Well, maybe exceptional cases and timings, but I think we really need to get some more information, right? Because you can clearly see it's not following the anatomical pattern here. So what is this though? Well, unfortunately, the patient did get a TEE, and if you see, it's a crystal clear aortic valve, right? So this was nothing but a slice artifact. Again, very important one to recognize, because it doesn't, when you see something like that and, you see the valve in the other views and it's completely fine, obviously you want to think, is it just the slice is off axis, right? Very important to know that. All right, let's get to the meat of the discussion, which is the Doppler artifacts or the ultrasound artifacts. Again, like I said, I don't want to torture you with too much of technical terms, but at least I want you to understand the physics behind each of these. Let's see if we can know the basics of ultrasound physics, right? So let's talk about sound, right? So when sound hits a structure, what happens? It can get reflected, right? Angle of incidence is equal to angle of reflection. What's the second type of transmission we can have? Right, reflects back, right? Straight up back. What about this one? Goes straight through, right? That's transmission. What about that one? Yeah, perfect, guys. You can take your boards tomorrow. All right, so again, all this depends on the propagation speed and also the medium itself, right? It doesn't necessarily have to be, the same in every medium. What about this one? This is actually the backscatter, right? That's the information which we get from the machine too, and this is the one which actually returns to the transducer, and we get the information from that. So again, let's not go into the names, but the most important one, reverberation, right? We're going to talk about comet tail or ring down artifacts, shadowing artifacts, enhancement artifacts, multipath or mirror image artifacts, refraction or ghost image artifacts, side lobe and beam width, and again few more names. We again talked about this, so I don't want you to worry about knowing the names, but know the concept behind it, right? So let's talk about the first one. So what happens when you repeatedly send a sound to a structure and keep getting, sound back? Now take your finger and tap the table in front of you, right? And imagine when there are a couple of structures in the way when you're sending the sound, right? You're going to get multiple signals back. Let's see. Send a second signal. But now the machine is hearing it from two different people, right? Or two different, reflectors. So what happens? So it places a second image right behind the first one. Now again, it's hearing again the same one, the same sound, right? Now the third reflector is going to cause the third one. So which one is the real image? The first one, right? So the first reflection, but then the others are all the backscatter or the reflections from the additional things in the path, which is the reverberation artifact. So key points, again, I want you to understand the concept here, right? So the artifacts are always farther than the original. So when you look at structures which have like multiple, reflections, think about the first one as the real one, and all the others are the artifacts. Another important clue is they are all at multiple distances from the original distance, right? So say if, me and Asma are here, she's the original reflector, but if I'm getting it from Dr. Deepan Shah, that's basically an artifact, right? But they are at equidistance from each other. Again, these don't follow anatomical boundaries, and remember, they always move in parallel with the real structure because, right? Like imagine something behind, it's moving with the heart, so you see the heart, and that's moving with the heart. And again, for the boards, if you see the term ladder or step ladder or anything like that, so think about a reverberation. Again, how to avoid? All our sonographers probably know this. They probably encounter this more, than us, and they try to put, alter the imaging plane, they do biplane, they try to sort out the answer for us and give the answer. So I just want to show you some examples, right? See these, how they are equally spaced? And look at this as well. And let me show you this moving image here. You see there are multiple kind of images or shadows right behind the heart, so all that is reverberation. Do we see it as an artifact, like, in an aorta? Yes, right? So sometimes if the LA or the wall of the aorta is too calcified, then you can actually see it almost looks like a dissection flap. But if you look, it will move with the aorta, and it will also be exactly twice the distance from the aorta too. So that's the clue there. All right, now if all these shadows which we just saw, what if they merge with each other, right? You're going to see like a continuous pattern, and that's what you're seeing right here, and that's nothing but a comet tail ring down, right? When they all merge and form a single kind of line, that's when you see that. And also sometimes when you see like, prosthetic valves, aortic plaques, like if you have like that variable kind of stuff, you can actually see the reflection as well. What about acoustic shadowing? Did anybody see this? You see that kind of dark band you see right behind the reflector, right? That's very common. We see it actually quite often, especially in patients who have severe MAC. You can see that dense kind of band where you don't see anything behind it. Acoustic enhancement is exactly opposite, right? When you have a hypoechoic or anechoic region, and again you have that kind of shadow right behind it, that's when you see that, right? Like for example, let me show you this. This is a cyst, and you see that bright band of echo dense band right behind it. That's basically acoustic enhancement. All right, let's switch some gears. Let's watch this clip. Well, why am I showing you this clip again? So I want you to remember this artifact, that's why. So that's a mirror image artifact, right? It's basically nothing but exact shadow of what you're seeing. Again, I don't want to go into the details, but again, imagine a structure right in the center of where you're trying to image, right? And this is creating first image from the object, and then a strong reflector is creating a second image, right? It will create exactly a replica of what you're seeing, and that's nothing but a mirror image artifact. And if you see, even color Doppler can be duped actually. If you see it's exactly the same structure with color in it, it's duplicated.
How can we differentiate it from the reverberation artifact?
So it's almost a reverberation, but it's, if you see the entire structure with the color, right? Reverberation is usually one linear one, which is usually behind it. What about this one? All right. Any other takers? Or you don't think there are two aortic valves? Especially after all this discussion, right, for the first few minutes. It's actually a ghost image or refraction artifact, right? So actually good thought, Salim, because side lobe is almost similar, but it's refraction here because it's almost creating a parallel image right next to it, right? If you see, it's actually getting reflected from this and creating a side lobe, right? Or side image right there, I should say. So again, change of sound direction on passing from one medium to another is the cause in this one. And it's, again, like I said, it's the side-by-side double image of the exact structure we are looking at. Let's see if you can guess which one of these is an artifact. I'll say A on the top and B at the bottom. Okay. No takers for B? All right, I'll give you a third option. How about none? And I know I'm not being fair because I'm not giving you the clinical context. So case A here is actually a case of a retained guide wire, unfortunately, is floating around freely. Case B, again, I should say it's not from Methodist. Again, online viewers, please, it's not from Methodist. So this is an unfortunate scenario where the patient was placed in the LV by mistake. And the patient was not like, a follow-up was not done for years together. Patient came in for recurrent strokes. And in fact, they realized the patient was inappropriately. All right. So again, why am I bringing this one up is because, we need to know the, clinical history. Very important to know the relevant clinical aspects. All right, let's move on to side lobe. I think Salim's favorite by now. I think we saw this image earlier in the talk as well. Whenever there are, so imagine when you're sending an ultrasound wave and you have multiple structures in the beam's main axis, right? You're going to get a major reflection from the structure which is of our interest, but there are going to be a lot of other things which are going to talk to us, right? They're all going to communicate the same, and that's basically the side lobe artifact. It's important to know, and especially in these cases, you need to alter the imaging plane, right? So imagine if you're changing the depth now, the whole imaging plane is going to change and you're not going to see whatever you're seeing earlier. So very, clinically relevant, I should say, and decreasing the gain can sometimes help, right? And adding color can also help. How many of you have seen this one? So you see there's almost a double line next to the atrial septum, right? That's nothing but a dilated aorta. It's in the elevational plane, right? But it's coming into this plane, so in between we are getting that signal as if there's a double shadow there. So important to recognize that as well. All right. What do we do next when you see this one? I think I have to point out, right, as to what I'm talking about. All right, I think all of you have guessed the answer, right? Change the imaging depth and alter the transducer location. Well, I think, most of you probably know what's the artifact too, right? Can you guess what's the artifact? I think the only one which we didn't cover so far, right? Which is a range ambiguity artifact, right? So again, remember, this is not something unusual in our lab as well, right? When you see those floating images, and you're throwing the color and you're seeing still something is floating outside the heart, you see in that image the wire in the right atrium looks as if it's outside the heart. So that's basically the range ambiguity artifact. All right, I think we talked enough about this. Again, remember, real structures are always there and they have independent motion. And again, attached to other anatomical structures and follow anatomical boundaries versus artifacts don't. And again, consistent in multiple views and at multiple imaging depths. If it's there, right? And then, like I said, if it's difficult, don't hesitate to approach multimodality. All right, let's move on to quickly color Doppler artifacts. I promise I'll keep this simple. Whatever we saw on 2D can happen with color also, right? It's important to know certain other artifacts though on color. The first one here is a reverberation artifact of color. This one here is a mirror image, and you see that the whole vessel is duplicated, right, with the color. This is a refraction artifact. You see the same exact one placed at the same depth. And this is a ghosting artifact, right? We see this quite often, especially when there are catheters, when there's a lot of calcium in the iotomitral curtain area, you see that. How about this one? The sonographers have to help us out with this. No excuse. What's happening between the left and the right? Color gain, exactly, right? So the left is actually, color gains are very low, and the right one is too high, right? How do you correct it? I think it's very crucial. Every time you turn on the machine, you're using color Doppler, always adjust that, right? Make sure you're going to the max and then come down until you see relevant color signals, right? What about this one? You've seen this one, right? So that's like a twinkling artifact. This one is a flash artifact. We see it sometimes when there's you're trying to emit structures which have multiple flows in the same view. That's when you see that. What about spectral Doppler? Do you think we have artifacts on spectral Doppler? Yes, right? All these weird names. But again, I'll keep it simple. So what we just saw on color can happen on spectral Doppler too, right? If you look at the first image, it's very bright, right? The second one, you know, the color gain is very low. So the bottom one, the C, is the one which is the optimal one, right? Again, remember, you're going to overestimate the velocities, underestimate the gradients if it's not appropriately done. What about this one? When you're trying to have a large sample size, right, you're trying to image like a huge thing, and now you're getting all these signals. In this one, for example, you're getting the mitral signal, and the AR is basically right on top of it, right? So for that, you want to avoid the sample size being too large. You want to make sure that the sample size is crisper, and you're just interrogating the structure of interest. What about this one? I'm sure all the sonographers have seen this, right? Impellers, LVADs, you see that kind of, you know, artifacts at the bottom, right? It's a horizontal streaking artifact. And again, mirror imaging can happen on spectral Doppler too. And look for the symmetry. Again, how do you recognize which is the real signal in this one, right? The brighter one is the real one in this case. So look at the, you know, signal and look which angle you're interrogating it from, and choose the brighter one. What about this one? It's like when you're trying to, you know, assess low velocities, make sure the gain is appropriate again. How many of you know what are wall filters? Right? All this, no? No? All right, so all of you, when you go back, this is another homework I should say, is to go back to the ultrasound machines and see where the wall filter, you know, button is. You can actually turn them up and down based on what you really want to filter out, right? That's the wall filter we use. Especially tissue Doppler is one where you really don't want all the unnecessary noise, and you can crank it up to where you see what the velocity you want to see. What about this one? Dr. Little, it's your favorite one. We see this very often, right? It's almost like a mitral valve double envelope. And I don't want to go into the details, but there was a big Twitter war about it, about is it real? You know, is it like from the hydraulic forces? There were theories about, you know, reverberations from the back wall of the LA causing this. But I think, you know, there were a lot of papers which proved that it was just an artifact. You know, it's just that the gain, you know, when it's cranked up, obviously you get that double shadow from the back wall, right? Anything to add, Dr. Little, to that, or?
You measured that one.
Yeah.
But why are these velocities increased?
No, it's just the doubling of the shadow. Yeah, it's from whenever you have that thicker, you know, calcified annulus, you basically get the shadow from the back side of the annulus too. All right, we're going to skip contrast artifacts because I think Dr. Zogby really elaborated them well on his contrast talk. So let's move on to quickly 3D ones. Do you really think all these can happen on 3D too? Yes, right? So again, I don't want to go into the names, but again, you can definitely see acoustic enhancement. If you see here, that's a very prominent blooming artifact, right? From all the calcium, you see it's like all kind of, you know, spongy. And this one is a dropout artifact. Actually, this is another one where we learned that please don't use TEE, like say there can be 3D dropout artifacts, right? So the valve is totally functioning well. But if you look at it, you feel like one of the leaflet is not moving well, right? But it's just an artifact. This is a stitch artifact. All of us know here, you know, we've had patients who have AFib or, you know, any irregular rhythms. And this one here is whenever you use those bigger catheters intraprocedurally, you can have almost like a railroad-like artifact, right? So that's basically that. All right, time to get back to your cell phones again. What do you think is this? These are some bonus questions to end our talk with. VSD, coronary flow, color flow artifact, or slice thickness artifact. I'll show you one more. I think all of you are guessing that it's an artifact. I think we are just struggling with the name of the artifact. Focus on the second one, the video at the bottom. What is that? That's just PI, right? That's a normal pulmonic regurgitation jet. So when you put both of them in the context, then you can see that it's nothing but the same jet you're seeing in the parasternal view, right? So this is nothing but actually a slice thickness artifact, right? When the slice is very large, that's when you start capturing what's going on behind the screen too. So that's exactly what's happening here. So it's a completely normal thing. How about this one? What are you showing? I don't know. What is this moving? Or are you going to say no more artifacts? I'm sure this is going to be an obsolete one, right, Dr. Q, in the next future, in the nearest future, this will be like, what is this thing we are seeing? I think most of you, will go with the don't know, right? Well, I can tell you that it's a ball and cage prosthesis. Now let's see. Why don't we see it? Did it embolize or did it shrink over time, or is it just because the power is too low? Why are we not seeing the prosthesis? Okay, maybe you can choose, right? Use your phones to vote. Maybe the options are too small, right? So the first is embolized, the next one is shrunk over time. I'll give you the clue, right? When we are trying to emit something, you have to think about getting it back at the same time as the others, right? So in this case, what's happening is basically the ball and cage is moving at a different speed. So you're not just quite getting the signal. So the answer is the slow and smooth motion, and because of that, it's misleading us, right? The signal is just transmitting at a different time. So important to know this one too, because it's not completely obsolete yet. I'm sure there are going to be some patients who still have that who are going to show up to your clinic. So important to know that, right? So again, finally, let's conclude. I'm sure all of you are tired listening to the ultrasound physics part, but I think it's important to know, at least the basics and know how to apply them in, interpreting common stuff we see. So again, true anatomy is always visible, explained based on principles of applied physics, and the key is to knowing how to avoid these, right? Don't even capture them for us to begin with, right? So thanks to all the sonographers, I should say, who do an amazing job. And again, coming soon, stay tuned for artifacts in echo for an ASC guideline, which is going to come out soon next year. And again, if something fishy, consider an artifact. All right, thank you guys.